Good morning, everybody. So, I would like to discuss briefly about reducing infectious complications and ECMO. Because from my experience over here, I saw infections are our main threat. In fact, interaction with microbials, they decide our lives. That's the reality. It's true all over the world, but more so in our part of the world. Looking at the infections, you need to worry about them prior to initiating ECMO. It could be bacteria. There are two types. One is pathogen, and which could be hospital-acquired or invasive. And secondly, the commensals and how much you need to worry about them. Probably there is a relation to immunity of the patient as well, immunological status of the patient as well. The commensals which remain with the patient when he is immunologically competent might become a pathogen when he loses that immunological competence once he is very sick. Viruses, practicality of doing viral screen unless you suspect a particular viral infection is less of a choice because of the cost factors. Fungi, yes, we do look for a variety of fungi, and antibiotic overuse might encourage the growth of fungi as well. The odd ones, rickettsia, typhus infections, I do see them as indications for going on to extracorporeal subacute as a result of ARDS picture. Infections on ECMO could be hospital acquired, relates to the duration of stay in the hospital and the colonizing bacteria turning into pathogens at some stage. They could be the factors while patients are in ECMO. Where can occur the infection first? This is a question which we need to answer for ourselves. Probably the flow across the central catheters from the insertions on the seepage along the insertion sites. But some of the odd factors against this are from the contamination point of view, with a high flow which doesn't allow the bacteria to grow very well in that high flow areas. And which type of technology you are using for insertion, which type of technique you are using, is it an open technique or a closed technique? Usage of biopatch, I will leave it to your wisdom to use it or not. It depends on release of chlorhexidine around the site of insertion for a prolonged period of time, like 7 days to 1-2 weeks or so. But this is just one additional measure available for us. And cleaning with chlorhexidine and povidone deuterium to keep these areas clean, that is very important as well. Recently, more information is accumulating regarding tunneling the ECMO cannula. Very soon we will be going for that as well to reduce contamination and bacterial growth at the site of ECMO cannula insertion. Central lines are another factor to consider. There are two types of lines. One is a plain versus antibiotic coated line. There is not much of evidence in favor of antibiotic coated lines, but they are available. Recycling the sites is important, but the risks are bleeding in a patient on heavy heparinization or reasonable heparinization on ECMO. Rewiring probably poses the risk of carrying the biofilm when you introduce the guide wire into these central lines, but that is an option as well for taking that line out and keeping a new line in. Certainly, aid of ultrasound for insertion of new lines is recommended. Strict aseptic precautions are a must whenever we do lines on ECMO patients, like any other critical care patient. And here also, usage of biopatch around central lines might be an additional measure. I do recommend using bionectors which allow flow to go in only one direction and just closes when it is left free. They can be used as well. Same precautions to be taken at the sites of in PIC lines and peripheral lines also. Peripheral lines can lead to thrombophlebitis once they extravasate, so please be very, very careful about that. Plastic within the body is a nidus for growth of the bacteria, so if you don't need any plastic, please get rid of that. Endotracheal tubes, tracheostomy tubes, etc. Be watchful about colonization and resulting in ventilator-associated pneumonia at some stage or later afterwards. Chest drains, how long to keep them in? That is a question as well. Ideally, from the concepts that they are likely to bleed from an area, if you take a deep line out while they are anticoagulated, it makes sense, but I haven't seen much of difference when you take them out a week or around that time, really, if you don't need them at that point of time, but it needs judgment from your side as well. Urinary catheters, theoretically they are a risk, but as they are needed on our patients, they do stay in for a variable length of period. Other septic focuses on the body, keep looking for any abscesses, effusions, arthritis, meningitis, osteomyelitis, etc., because these could be harboring bacteria as well. The other procedures we need, physiotherapy, it is very essential to improve the lungs. Once the patient goes on ECMO, and it gives a lot of opportunity for us as well to do the chest physio, and it is not related to participation of lung from oxygenation point of view. And suctioning of the airways, as I mentioned earlier, though inline suction is sometimes useful for keeping the FRC, but as you go on to ECMO, you don't need that as such, and I do recommend direct suctioning of the airways with good chest physio to improve the lungs, especially the bronchoscopic suctioning on alternate days at least to clear the lungs and with the integrity of the membrane. In our experience, we haven't seen much, but I need more and more evidence in favor of that as well for using it as a first-hand medication when you are suspecting aspergillus. The other medications are oriconazole and echinocandins. Most important is prevent cross-contamination. This is one of the patients at Krishna Institute of Medical Sciences, a tiny one on ECMO. The environment, there should be sufficient place for the ventilator, ECMO circuit, infusion pumps, and CRRT if needed. So it should be a wider area. Humidity and air conditioning are very important as well. If the humidity exceeds 55%, that leads to the growth of bacteria and growth of fungus, more so the growth of fungus. So be very careful and watch the humidity levels in your immediate environment. Role of fumigation, though in theory there is not much of recommendation, but I do find it being useful over here. Mapping the floor is extremely important. We don't pay much of attention to activities which are done by IAS, etc., but there is a greater role for them in preventing the infection. One needs to look into that as well. How much education do they get and how are they monitored? Cleaning the contact surfaces with chlorhexidine, like infusion pumps, ventilator, and ECMO console, knobs, etc., which should touch on a daily basis. They should be cleaned more often. Barrier nursing in case of hospital-acquired infections is very important. The role of probiotics, probably after a week or so, if the patient is not immunocompromised, I might go for the use of probiotics also, as most likely as a result of broad-spectrum antibiotic therapy you have lost your friendly bacteria. So I do think of probiotics as my personal practice after a week of broad-spectrum antibiotic therapy. Oral hygiene and bath, they have a lot to play as well. We do use chlorhexidine for mouth care and chlorhexidine for giving wash as well. That reduces the bacteria. It doesn't eliminate and don't make you sterile, but it reduces the bacterial load. Daily cleaning and keeping the patient dry is important. Avoid pressure sores from the bed point of view. Infected material has to be disposed in the right way and make attention to linen and disposal of needles as well. Lastly, we live in a bacterial world where we will never be able to stay ahead of the mutation curve. So be extra cautious about usage of antibiotics and prevent abuse of antibiotics. As it is rightly said, we are aliens in this bacterial world. Prevention is the best. Treat the infections, don't give new infections. It's a team behavior that decides. Have a vigilant eye in your own environment, and you have to be the advocate for preventing infection in your own environment. It includes doctors, nurses, physios, ayas. Everybody have got their contribution. Unless the team behavior is right.